Now starting. Yeah, now starting. Okay. All right. Good evening, everyone. I see Abdullah and Osama with us. Abdullah, you want to start, Abdullah? Let's go and start. Continue carotid.
Inshallah. So this case is 70-year-old woman with no significant past medical history, present after referred by her primary care physician for evaluation of a left neck carotid bruit. She denied any neurological symptoms or vision changes. CT angiography showed significant tortuosity in her left internal carotid artery with minimal atherosclerosis disease. The appropriate management of this patient is. So this patient has tortuous left internal carotid, and as per the question, she is asymptomatic. Problem with tortuosity, the patient may get TIA or stroke by changing the position of the neck that may kink of the internal carotid, and she may have TIA. But here it's clear she is asymptomatic. So
let's talk about the guideline. What the guideline tell us about, kink or elongated ICA? If they're asymptomatic, what's the best treatment?
I think it's
only conservative or surgery or stenting.
I will go with conservative.
Yes, the guideline said if you have asymptomatic kink or or web in the ICA and asymptomatic, then conservative. Usually we give what we give as conservative.
We will start her on aspirin.
Correct. And statin, right?
And statin.
We give statin. So aspirin and statin, right? So yes. The question now, this is an easy one, but the question, what if she has the symptoms? What we do? Do we do a surgery? Do we do a stenting?
Yeah. She is 70 years old with no significant past medical history. So I will go with the surgery for this patient.
Right. I mean, you can go, but I'm talking about the guidelines saying. Let's talk about the guideline because we don't want to talk about our own experience. We want to go about guidelines. So what the guidelines said, if you have an eye elongated or, kink or web in the ICA, what is asymptomatic? So what they recommend? Surgery, stenting, or none of the, or medical management?
Surgery.
Surgery. Okay. Why not stenting?
It is usually it is tortuous, so it's not that easy. Like straight forward carotid.
Yeah, but we have a stent which is very flexible now. They put stent inside the brain, right? In the ICA, inside the internal, in the cerebral arteries. They put small stents. Our stent now become very flexible.
Yes.
So why not put a stent? It's easier.
I think still there is the same, maybe.
No, because Abdullah, what the issue here? We don't have a disease. We have a kink, right? Because of elongation, yes. Right? So yes. Straight this kink, what happened? You just push this kink to the other part, right?
Yes.
If you have a tube and straight it one side, long tube, you will fix this part, but this kink will transfer to other side. So you're not doing nothing really. You follow me? You yes. Imagine the situation. Yes. You have a kink. So you put a stent, you straight it, but this kink has to go somewhere. So it's going to be transferred to the area after the stent.
Yes.
Then if you put another stent, you're going to go after the stent. So stent is not a solution because you're just transferring the kink from one side to another side. So the only treatment really for carotid elongation or kink is surgery, if it's patient symptomatic. But before you take him to surgery, the guidelines tell you to have an MDT because it's not very convincing many times that the kink can cause a symptoms. So really you have to have an MDT meeting, talk with neurology and be sure 100% this symptom from this kink because the majority are asymptomatic. So before yes. the guideline said if it's asymptomatic, medical management, if symptomatic, you can consider surgery, but after MDT meeting, okay?
Yes.
And the surgery will be, it's a carotid enterectomy or, but let's go through one by one, okay?
I think
Let's
A
go.
is the answer for symptomatic. So we will resect the elongated part and we reinsert the internal carotid to the common carotid. So A, resection and reimplantation of internal carotid artery into the common carotid artery bifurcation. This is the treatment of symptomatic.
Okay.
B, carotid artery stenting across the area of tortuosity. We said we will change the area of tortuosity by stenting. C,
Right.
initiation of aspirin and statin therapy. This is most likely the correct answer. Let's see the rest. D, initiation of aspirin and statin therapy with plan for elective carotid endarterectomy in the future. No rule for carotid endarterectomy. So there is, because there is no atherosclerosis, even it's not stenosis. E, carotid endarterectomy with batch angioplasty. Again, the problem is the tortuosity, not the stenosis. So the
There's
answer
no
is C.
stenosis, really. Yeah. So there's no stenosis here. You have just elongation and kink. And
Yes.
that took me who doesn't have any. So the most, as you said, when you have to do it for kink only, just resect it, make it shorter, and reimplant it like an inversion technique,
Yes.
But I can tell you, I never, and Omar was asked, he can see what his experience. I never had to do surgery for kink. Yes, I did surgery for ICA stenosis and kink. I see them both. Sometimes ICA has severe stenosis, and then patient has a kink. Then doing a surgery, I fix them both, but it has to be a significant kink, Then I do endarterectomy. Then I shorten the ICA, and then the way I shorten, you don't cut the ICA, you just cut like a wedge from both sides. Make a wedge from both sides. You keep the CA wall attached. Then you suture it posteriorly, so you shorten you make the ICA shorter, and then you put a patch interior. So this is the only time I used I have to shorten the ICA, but I never had to go to surgery for carotid kink alone. But maybe Omar has more experience. What do you think, Omar?
No, no, no. I have the same experience. I have not operated on just a single kink, just a kink with stenosis. And even with MDT, there was some cases where they advocate to do shortening of ICA because she was symptomatic without stenosis, and I told her you might get a stroke, frankly. And I didn't do the case anyway. It maybe went to someone else. So we all, as a surgeon, are reluctant to operate on kink because, as you said, the stroke is an embolization phenomena, not a hemodynamically significant phenomena. The bruit in the carotid area does not have any prognostic value. You can use whiteboard in your screen. I know you like to draw, Samer, which really give a lot of help to candidate when you draw. How do you do your patch thing? So if you open your screen, down below you found whiteboard, and you are the only one allowed to use whiteboard. If you have a touch screen and pen, it will be easier. But my experience is same as you. I think I've done 2 cases with kink and significant stenosis.
That's good. Yeah, but I just want to mention something. Omar, he just mentioned it now, that even symptomatic, we don't rush to surgery, of course,
Yeah.
because we don't have like criteria like 50, 60%. So even patient with symptomatic is only if failed medical management. Of course, even symptomatic has to be medical management. Surgery should be has a last option because we don't have a criteria like ICA, like velocity more than 300, then you have to do hemio. I think even symptomatic, I will go with the medical management. And let's not say that we need MDT, unless if we get to the dead end, like, he still have a symptom TI in spite of like dual antiplatelet and statin, then it may consider. But I never in my career have to have something like that. So I think it's very rare. If you have to go there for just carotid elongation,
And another point for a duplex scanner, for someone, I usually do my carotid duplex scan. Kink in the carotid is a nightmare. You could really, very, very difficult to get a peak systolic velocity. You don't know where to measure it. You don't know, it is variable. Sometimes you get a 360-degree kink, which it take a complete circle and then continue upwards. Sometimes you get lesser kink, and internal carotid and I think the splenic artery are the only two arteries where can have 360-degree kink. And this is unusual in the human body. And it is, I totally agree, surgeons are more conservative. And you mentioned if you put a stent, although with nitinol, you just push the kink upward, and you actually can convert the kink into a total occlusion. Sometimes it happened with us, which was mild kink. Once we put a stent, it become an occlusion. And then we have to put a kink above it to relieve the occlusion. So before you start, and this is one of the contraindication of carotid stenting, is severe kink.
That's just true. And this is a very good point that if you decide to carotid stenting for ICS stenosis, you have to watch the kink. If it's severe kink, as Omar said, it may convert to occlusion. So you have to be very careful. This case may not be a good candidate for stenting, but surgery. So this is something that's very important also, because it's not uncommon to see ICA elongation and kink, you know. Right. All right. Well, let's go to next question. We have Osama. You want to take next question, Osama?
Yes, Dr. Samer.
Okay, let's go there.
An 81-year-old patient who recently underwent a right carotid artery endarterectomy for asymptomatic carotid artery stenosis of more than 70%, complaining of chest pain on post-operative day 1. Which of the following is the strongest predictor of myocardial infarction after carotid endarterectomy? So in our case, patient underwent right endarterectomy for asymptomatic more than 70% and develop cardiac symptoms post-operative day 1.
Okay. In the exam, guys, most of the question will come for asymptomatic. Well, this is a controversial issue. Very rare, I think, you get a question for symptomatic, because symptomatic is straightforward. All the controversy and data is about asymptomatic. So try to get yourself familiar with the asymptomatic trials, you know. For surgery, ACAS and AKCST are the two major asymptomatic trials, even from 1992, but they're still valid until today. So please, guys, before you go to exam, go through these two trials, read them very well, because again, even from the old trial, they're still valid. For stenting, CRIST trial is the most important. So also go and read about CRIST trial, because this is the most common transfemoral carotid stenting trials. And for TCAR, which is very new now, everyone doing TCAR, we have the Roadster trial. So try to read it. So just guys, from my advice, this 4 trial, you need to read it for carotid surgery in general. So here they said what the strongest, because all of them are really predictor of MI. They just want what the strongest predictor. I mean, there's nothing to think about this question. You just have to know it. You have to go through the trials and see what they said. So I don't think we have much to talk about it here. All of them can cause MI, but the strongest one, do you want to guess, Osama? It's just guessing. I think you have to guess if you don't read the trials.
I think it's poorly controlled diabetes, I think.
Is it what makes sense? But the trial said a coronary artery disease, what I'm saying. I think this is what the trial said, but you just have to read about them, you know. But all of them are poor controlled diabetic disease, yes. Peripheral artery disease, yes. Active smoker, age, coronary artery disease. But the trial, they found coronary artery disease. So again, there's nothing in this question to think about it. And I don't think we have much learning point from these questions. But again, please guys read the ACST 1 and 2. We have 2 because 2, it's after 10 years. We have like an update. And then ACAS, CRIST, and Roadster trial. Omar, anything to add?
No, that is exact good summary to all the carotid trial that you should learn before the exam. Absolutely right.
You agree? I mean, ACAS and ACST and ACAS studies, and still until today is valid. I'm surprised from 1992, but still valid now, and still we get a lot of recommendation from these 2 trials because there was the largest trials really.
Yeah,
all right,
true.
Let's go to 18. Barak, want to take this one, Barak?
Yes, Dr. Samer.
Go ahead.
82-year-old right-handed active woman with history of recurrent episode of transient slurred speech, and dysarthria present for evaluation. She lives alone and does not have any other significant medical history. The patient recently underwent coronary catheterization that showed no significant coronary artery disease, and she was initiated on aspirin and statin therapy. Carotid duplex showed more than 80% left carotid artery stenosis. CT angiography of her neck was ordered. What anatomical feature on CT angiography are contraindicated to transcarotid artery revascularization in this patient?
Okay, this is what we call the TCAR, correct?
TCAR, yes.
I'm sure you're going to get out of question about TCAR because this is a hot subject these days. Everyone jumped to the TCAR. So I'm sure you're going to get out of question. So it's very important to know what the indication, what are contraindication for the TCAR, okay? So she's symptomatic 80. So we know that she needs a surgery, whatever, surgery or stent, but they want to do a stent here. And they want to do a TCAR. So they want to ask you about what the contraindication for, you know what the indication for is for TCAR?
Yes, if the patient is having bad aortic arch or difficult access from the femoral or radial or brachial axis, and he is not fit for carotid endarterectomy, then we go for TCAR.
All right. He mainly is the arch because they found that majority of the stroke happened during manipulation when you go through the arch. Because this one, it happened, you go through the arch without even before putting a filter. That's why you get embolization. And during angiograms, they did studies, they found most embolization happened during arch cannulation and during angiogram. Then when you go to ICA, dilatation, then you get the third like hub of the embolization to the brain. So TCAR, you can bypass the arch, which is big plus, especially if you have arch type 3. Type 1, it's easy. Type 2 is moderate, but type 3 is difficult. And then you have to do a lot of manipulation from transfemoral. I think these days in Europe and States, almost transfemoral stent become like an obsolete. Nobody does it anymore. In Middle East, we still do it here. But I think in Europe and States now, TCAR is the first choice if you decide to go with a stent. But to do a TCAR, you have to have a criteria, okay?
Yes.
Can somebody share some of the criteria? It's a lot of criteria. What's some of the criteria you have to have it?
You need to have at least 5 centimeters from the clavicle to the carotid bifurcation.
Correct. So you have a space to put your sheath, you put a clamp, you know?
Yeah.
So this is
Yes.
important, correct?
Yes, you need the diameter of common carotid artery at least 6 millimeter and the internal carotid artery at least 4 millimeter.
Okay.
And
but this is mainly, this is not, I agree with that, but this is not only, this is for any stent, because less than 6 or less than 4, you can put even a stent. So this is, yes, this is for TCAR, but even for transfemoral is the same. You cannot put a stent if the IC is less than 4. So, but it's correct. Okay, what else?
you need to have a patent femoral vein.
Patent femoral vein, correct, because you need to drain the, you know, to the femoral vein. Okay.
And also you need to have a patent ipsilateral internal carotid artery.
Patent.
External carotid artery.
You have to have it patent.
Patent ipsilateral external carotid artery, yes.
Okay, let me put a big question mark on this one. This is correct, but not in TCAR. You know why it is correct and why?
Because you will insert
why need
wire
external
first
to be patent? Why need that, huh?
Because you are going to insert the wire first in the external carotid before you insert the sheet. And then you will exchange to the internal carotid artery.
This is correct, but this is when you do TCAR or transfemoral?
I think both.
No, why need? And TCAR, everything is open in front of you. The common carotid in front of you. Just put small needle and put the sheet, and that's it. I mean, yes, there's the wire, but you don't have to go the wire too far. Where in the transfemoral, you have to go the wire very far to give you some stiffness, so you can push the long sheet all the way to common carotid. You follow me?
Yes.
So in the transfemoral, external, yes, has to be open, so you can go with the wire all the way to the external. So you have a long wire and a stiff wire, because the first part of the wire is soft. You cannot depend on it. So you have to go really deep in the external carotid. Then you have the stiff part outside. Then you pull your sheath all the way to the common. But if you're doing direct puncture, you just need to put a needle and just advance the wire like maybe 1-2 centimeters just to get the sheath in, and that's it. You don't have to get, and then you put your filter and then you do reverse and everything. So I think this is correct, but in the transformer, not T-car. Okay.
Okay.
What else?
So first,
no, forget about
I
the question. I'm talking still about the criteria for the T-car. Then the common carotid has to be free of atherosclerotic disease. If you have like disease, common carotid, plaque, all this, shaggy common carotid artery, it's not good for T-car, right? Because you may cause embolization
Yes.
before you do reverse flow. So this, I think you have to look at that. So,
Yes.
okay. So let's go through one by one.
A, circumferential calcification at the carotid bulb. I think
Okay.
it is correct. B, distance from
Contraindication.
carotid bifurcation.
But the
It
second
is
before,
contraindicated.
let's go to this one. Why this contraindication?
You need to do pre-stenting balloon dilatation.
Okay.
It may
we
rupture the
don't
plaque.
do pre-stenting balloon in general in the carotid stenting. We don't do pre-balloon dilatation because it can cause embolization. So usually you do primary stenting, unless it's very tight stenosis, like 90% you can get stents through it. You may balloon with very small balloon, 2 or 3 millimeter, just to get the stent through, and then you deploy it, and then use balloon after the stenting. This will decrease the chance of embolizations. I mean, this answer is correct, but the problem, this is not for T-car, for every stent. So this is my problem with this question. So circumferential calcification of carotid bulb should be contraindication for transfemoral and T-car, for both. It's not specific for T-car, because when you have circumferential stenosis, it's very hard to put a stent because it will not expand. So this is the right answer, but I think the question is not very well written, Let's go to the next one.
Distance from carotid bifurcation to the clavicle measures greater than 5 centimeters. This is correct. It's not contraindicated.
Correct. Okay.
Type 3 aortic arch. This is actually an indication for T-car.
Correct.
Occlusion of the right external carotid artery.
Okay. It's not
As you mentioned, it is for transfemoral.
Correct.
And severe atherosclerotic disease with more than 70% stenosis in the contralateral carotid artery. I think it is not contraindication.
No, this is an indication to do a stent, right? He has 70% stenosis. This is the indication to do a stent. So the right answer is A, even though I'm not very good question. Okay, let's talk. Omar, he has very good experience about T-car. So let's hear from Omar.
No, it's because expenses.
You like T-car. Yeah,
I haven't done a single T-car in Egypt. It's so expensive.
Yeah, the same in Saudi. We don't have it really.
Yeah. But I totally agree. You did mention very good points for carotid stenting. And it is a tricky question, not an easy question, but you did tackle it very, very nicely. Nothing to add, no.
Okay, thank you.
Yeah.
All right, well, let's go. Who is else? Maitham, you want to take this one, Maitham? I see your name here. Not with us. Okay, well, let's go back to Abdullah.
Yes. A 65-year-old woman presented to emergency department 3 days after left carotid endarterectomy for evaluation of severe left-sided headache that started several hours ago. Her blood pressure 184/95. She is taking aspirin and statin, but is not currently on any antihypertensive medication. Her post-operative course was uneventful, and she was discharged on post-operative day 1. She is placed on beta blocker therapy in the emergency department. Which of the following finding in this patient history would put her at high risk of cerebral hyperperfusion syndrome after carotid intervention?
Okay, so what does she have? What we called it? Hyperperfusion syndrome, right?
Yes.
Cerebral hyperperfusion syndrome. Omar, you want to talk? Maybe I'll give you some chance to talk and discuss it. What do you think, Omar? Yeah, please.
Hyperperfusion syndrome is a syndrome that all vascular surgeons doing carotid endarterectomy should be fully aware with, mainly due to hyperperfusion to the brain. So you convert the patient who have an emboli internal carotid into high perfusion area. In some people, it can cause bleeding. In other people, it can cause severe headache, which is called hyperperfusion syndrome. The main treatment is to control blood pressure. Sometimes it triggers a spasm into the intracranial arteries, so you must consult the neurologist, have a multidisciplinary team with you, because sometimes you need to give nitrates. Definitely controlling blood pressure is the most important factor in hyperperfusion syndrome, and to exclude intracerebral hemorrhage. This is essential, and it is luckily not a frequent post-operative complication that we see after carotid endarterectomy. But it mentioned it's usually to hypertensive patients who are not taking hypertensive medication. This patient systolic is 184/95. So this is what you should know about it, and you should deal with it. And sometimes it can have a catastrophic consequences. It can convert into stroke from the hyperperfusion syndrome. So although your operation was done, your perfusion is increased, but unfortunately patient got a stroke. And this is one of the danger about this carotid operation. That's why they call carotid endarterectomy as the Cinderella of all vascular procedures, because it is extremely technical. You must be really experienced to do the carotid area. So this is what you need to do. And he mentioned here the multiple factors that predispose to hyperperfusion syndrome. It's very important to know each one of them, and then to select which one have more risk to develop, because usually I pick them up before the operation. Yeah,
I think
here is the table. Excellent. Yeah. The table risk factor of several. Yeah, go ahead. Yeah.
The only thing, guys, I want to just mention one important factor is that when patients have a headache, right after surgery, after 3 days comes severe headache. This is most probably is cerebral hyperperfusion syndrome. But you cannot depend on your symptom to decide that, because it could be intracranial bleeding. So for me, before I claim hyperperfusion syndrome, I need to get a CAT scan. So for me, any patient after surgery, carotid surgery, come with severe headache, my first thing to get a CAT scan. If the CAT scan is negative, then it's hyperperfusion syndrome. But it's not acceptable to patient come severe headache and say, okay, he's fit the criteria for hyperperfusion syndrome, and say, okay, I'll just treat him conservative control blood pressure. And then later on, you find he has a bleeding, and then you end with a major, problem. You agree, Omar?
I totally agree completely. Yes.
Yeah. So again, any patient, guys, you do surgery, next day come with severe headache, like you come to see patient next day and he has severe headache, get a stat CT, brain CT. Most of the time, nothing, as I said, it's hyperperfusion syndrome, but again, you don't want to miss intracranial bleeding. So please put this in your mind. And this is the criteria. I don't know where this criteria came from, but you just have to memorize it, guys. So if you apply this criteria to the question, I think our answer will be, let's go through one. This will be A, I think, conclusions. But why the rest, where they came, already, I don't know. They just put this criteria, must be from different studies. So again, it's not very important, this question, but the most important for you guys to know is that severe headache after carotid surgery, please do CT brain. If it's negative, treat them as hyperperfusion syndrome. All right, well, let's go to next questions. What is it? I think I passed it, right? Yeah, this one, 20, right? Is that 20? Yeah, 20. Who's want to take it? Osama?
Yes, Dr. Samer. A 63-year-old active woman present with an episode of acute onset loss of Sorry, the question is, can you minimize the screen a little? Because the question is not complete.
Already?
Yes.
It's okay now?
Yes. Yes, thank you.
Okay. You're welcome.
She's 63-year-old active woman present with an episode of acute onset of loss of balance, dizziness, and an episode of syncope. CT angiography shows less than 50% stenosis of the bilateral anterior carotid arteries and focal 80% stenosis in the V1 segment of the left vertebral artery. A transposition of the left vertebral artery to the common carotid gland. Which of the following complications is unique to open vertebral artery revascularization procedures?
Before we go to that, let's talk what the guidelines said about vertebral artery stenosis. If you have a severe vertebral artery stenosis,
Yes,
and patient asymptomatic, 90% asymptomatic, what do you do?
80% asymptomatic.
90%.
90% asymptomatic, conservative management.
Yes. So all asymptomatic vertebral artery is conservative, okay? Not like the ICA. But let's say patient is symptomatic. What is your first line? Is stenting or surgery? The guideline.
I think the guideline, I think, is stenting is because
stenting, correct.
Yes.
Because it's much easier. The reason why this question, I don't know why about this question, because the first line really of vertebral artery is stenting, with even the drug coded stent will be better if you have it.
Yes.
But yes, it's stenting. But let's say you did a surgery, which I never did the surgery. I know Omar did. I never had to do surgery for well, let me give it more not complicated, but we discussed that before. Let's say you have vertebral artery stenosis and ICA stenosis, and patient come with syncope. Which one you do? Do you do them both? You do one of them? You do which one you do?
That's
Like
I think
80% left internal, 80% left ICA, and he come with syncope.
We will treat the carotid lesion, and we will observe for the vertebral lesion, and we will see. If it is still symptomatic, then we can go for the stenting. Otherwise, most probably it will be solve the issue completely with fixation of the carotid. I think that's what we discussed before.
Correct. That's correct. Why don't you do them both same time?
I think high risk of stroke and even mortality. Yes.
That's good. You guys are paying attention. Very good. Yeah. So this is the right answer. Okay. So let's say if you decide to go with surgery, what the most common complication with the vertebral artery?
We'll take it vestibulocochlear nerve palsy. Actually, I'm not sure about it. Vision loss.
Okay. This is a posterior circulation. I think there was a vision loss, unless if you get embolized to the occipital, but it's very rare. Yeah. They said they want the most common, right?
Yes. Yes. Horner syndrome. I think this is the nearest one, possibly. Yeah. Ischemic stroke. Laryngeal nerve palsy. I'm not sure, but I will go for Horner syndrome. I'm not sure.
You see, the question they said unique. You see, look at that. They said unique. Where is it here? Which of the following is unique?
Yeah, unique.
You see, so that means they want which one's a vertebral, because vision loss can happen in any of them, in the vertebral and ICA. Ischemic stroke the same, laryngeal nerve palsy is the same, visceral nerve, but Horner syndrome is unique in the vertebral because you have to dissect it deep, and you can get to the sympathetic plexus. Yes. So this is the problem with vertebral artery. I don't think much. We talk about vertebral artery. Omar, you want to add anything about vertebral artery stenosis?
It is just a very common procedure, vascular procedure in France. So if you are going to European Board of Vascular Surgery, some of the examiners have done 100 of vertebral artery revascularization. It is strange, but this is their vascular practice. And you are absolutely right. What is unique? You must read exactly what the question wants. And Horner syndrome, what is unique from the incision, especially V1 area. We know that vertebral artery are 4 areas, V1 to V4. And the most difficult to tackle with surgery is V1. Obviously, another area cannot be tackled with surgery like V3 because it is in the transverse process, so only be tackled with endovascular. I usually do, if one vertebral artery is affected, the contralateral vertebral artery is free and basilar artery is free, I don't intervene. There is one problem for young consultant on his first day. Don't make in your first 6 months vertebral artery revascularization, because if you have a distal embolization, it can go to respiratory center. And I have witnessed a patient which have emboli, single emboli, but respiratory center. She was age 32, female patient, and she spent in ICU more than a year before she recovered. So the information for junior, vertebral artery, either surgery or endovascular, is with an experienced vascular surgeon and must be multidisciplinary. This is what I have to say.
Agree. And I think the best one to do it is a neurointervention. So when I have an ICS stenosis need to treat it, I don't do it. Even technically it looks easy, but this embolization is a disaster. So you need somebody who has experience. If you get embolization, how to get it behind it. So I think ICA vertebral artery stenosis should go to neurointervention, really, be my advice. Because stroke is a disaster. I had a patient who had subclavian artery thrombus. So I was putting the thrombus, and one of the small clot went up to the vertebral artery, and she went to the what's called a Luck syndrome. It was very devastating. So yes, vertebral artery embolization is very, very bad. So please, even if you have a bleeding, sometimes I have a case, we're going to write it. They're putting central line and they injure the vertebral artery. They have a bleeding from vertebral artery. Even though it's easy to put a cover stent, but we called the neurointervention. He went there and he put a stent, and one other case he coiled it. So it's because he go from the other side and he can go and coil it. So vertebral artery, I think, if you want my advice, it should go to the neurointerventionist. Yeah. I think that's all about carotid vertebral. The only time we have to do a surgery, you may face it really in practical life. I think we did case or two where the vertebral artery coming from the arch, and patient has an aneurysm or dissection, and you have to cover from common carotid all the way down. So then you're going to cover the subclavian and the vertebral artery, because vertebral artery coming directly from the arch. So this patient, we did carotid subclavian bypass, and then we have to cut the vertebral artery and reimplant it in the common carotid artery. This is the only case I remember we did that, because we have to the vertebral artery was large, and we have to keep flow to the vertebral artery. All right, let's go to the next question. Who's that? Barra, you want to take this one, Barra?
Yes.
Okay, let's go
Prof
to that.
Samer, I think we escaped one question.
Really? Going too fast? This one? Oh, you're right.
Yes.
Okay, let's do that.
Okay, 67-year-old right-handed woman with type 2 diabetes, hypertension, hyperlipidemia, present for evaluation for an asymptomatic 75% left carotid artery stenosis identified on cerebrovascular duplex examination and confirmed with computed tomography arteriography. Data from randomized control trial regarding carotid endarterectomy for asymptomatic carotid stenosis in women versus men suggest.
Okay, so this takes us back again. As I said, this is the trials we keep: ACAS trial and ACST trials. They're from 1992. Still until now we take them, so you need to read these trials. So they want you to know what about humans in these trials, not in general, not the new update from the other trials. They specify these trials. So you have to be careful, because you may have like a new trial that is no different between men and female. But when they specify they want these trials, then you have to answer according to that trials. Okay, so you have to be very careful with the question. So in general, who has a worse outcome with a carotid surgery, woman or men?
I think woman.
What do you think? Woman, because the arteries are smaller, right?
Yes.
And they have higher chance of stroke and death, and we have more coronary artery disease. So usually women have more complication stroke during surgery than men. So the outcome is really worse with a woman than men. Okay. So this putting in your mind, let's go one by one.
Carotid endarterectomy is more beneficial in women compared to men due to their longer life expectancy. I think no. Carotid endarterectomy is less
Yes, they
beneficial.
live longer because they kill us early. That's why they live longer.
Carotid endarterectomy
Anyway, that's
is
wrong.
less beneficial in women compared to men due to lower rate of stroke.
Okay.
It is less beneficial, but I am not sure because of lower rate of stroke or what it is
What?
for asymptomatic woman. For asymptomatic woman, it is less beneficial.
Why less
Uh,
beneficial?
it is written in I think in
Okay.
ACST and ACAS that for asymptomatic woman they don't get any benefit from the carotid endarterectomy.
Not any benefit. Yes, I tell you why. Because the stroke rate in women compared with the men is lower. You see? So you're starting with low. Like, I mean, men, let's say 10%. With the surgery, go to 5. So you get like, 50%. But if you start with 6 and you go to 5, it's no benefit. You see my point? So when you have a
Yes.
low rate of stroke, then the benefit of surgery become less. When you have high risk of stroke, the benefit of surgery become more. So women, they have lower rate of stroke after surgery, but before surgery, they have really higher rate of stroke. So you have to, don't get confused. So before surgery, women have less stroke rate than men, but if you do a surgery, then the woman higher risk of stroke and death. So you have two things against you to get benefit from asymptomatic. You have less benefit because less lower stroke before surgery, and you end with more stroke and death after surgery. So all go against the benefit you get from asymptomatic carotid surgery. Okay?
Yes.
Clear? Okay.
Clear, yes.
So this answer should be correct.
Yes.
Okay, next.
There is no benefit for statin administration in women following carotid endarterectomy. This is wrong. Women have lower risk
All right.
of preoperative stroke.
Let's talk about statin. I think we have to learn from these questions. So what about statin? Does it help or not? In general, men and female, do they help?
It is it is one of the gold standard. It is part of best medical therapy for asymptomatic.
Right. And one of the criticism for ACAS and ACST study that there was not using statin. So a lot of people, they changed them. They said, guys, you are not using statin, but since we use statin, you should ignore all this data from ACAS study. But the study, they did a follow-up. This was ACST2, where they look at the statin, and they found if you take statin, yes, it will lower your risk of stroke, but in both arms. So you still get a benefit. I don't know if you follow me. Like patient had a surgery or medical management. If you get statin, they go down both. But the difference between them is still there. So still benefit even if you take statin. Okay?
Oh,
So
yes.
statin, it lower the stroke rate in both, but still it both in surgery and without surgery. So this difference still there. So still benefit from surgery even with the statin.
Yes.
Okay. It's very important to understand this point because the way they criticize this trial with the statin, Okay.
Yes. Women have a lower risk of preoperative stroke and death compared to men.
No, we just said that, right? They have higher chance of stroke and
They
death
have
after surgery. So this is wrong. Okay.
Women have a lower rate of carotid restenosis requiring re-intervention at 5-year follow-up compared to men. I don't know.
Usually, woman has a higher chance of stenosis because the smaller artery, unless if you patch it. But in general, if they didn't tell you here, did you patch it or not? In general, because you have small artery, you expect to have more stenosis, or at least the same. But I'm sure it's not lower rate of stenosis. Okay.
Okay.
Should be wrong. Omar, you want to add anything especially about statin and these trials? I think I missed.
No, just a friend of mine called Martin Stork from Germany. He is specialized in giving lecture about carotid in women, carotid disease in women. And because he is my friend, I used to attend his lecture. So
Okay.
carotid atherosclerotic disease, as you exactly mentioned, it affects women to a lower degree because they are protected with the female hormone, estrogen and progesterone, but they are usually have smaller arteries, so they have more higher complication when we do endarterectomy. And I remember when my first day was a consultant in UK, the one before me told me always be wary of female with the small arteries. And he's absolutely right. If I go to my complication, either peripheral disease or carotid, not a small number of them were female with a small artery. That is absolutely right. But nothing to add from my side.
Thank you. Thank you. All right. Let's go to next question. Where's my other fellows? Anybody guys from other side fellow want to take any question? You are more than welcome. Just turn your microphone on and you can answer questions.
Prof Samer, can I
You
take
have,
the next one,
yeah,
please?
you have 24
Yes.
attendees, so I think a lot. Yeah, Dr. Ahmed, he did raise his hand for a while.
Okay.
I
So
think
let's
he had a
Dr.
question.
Ahmed. Question. Go ahead, Dr. Ahmed.
Yeah, thank you. A 72-year-old man with hypertension and diabetes mellitus who is on hemodialysis presents for evaluation of an asymptomatic 80% right internal artery stenosis. Important considerations for carotid arterectomy in asymptomatic patients on hemodialysis include asymptomatic 80% stenosis, right? ICA.
Well,
Okay,
let's
and
before we go,
hemodialysis.
Ahmed, before we go, make it simple, guys, for you. Patient with the hemodialysis is the worst patient. Anything is worse with him. Anything. Even peripheral vascular disease. If you compare, stenting in patient on dialysis, not on dialysis, is worse. So just put in mind, anything comes in the question about hemodialysis patient, things will be worse. So you have to be very careful when you select patient treatment for patient. Renal failure is diabetes is one risk, then renal failure second risk, and then third risk is dialysis. So if patient is diabetic, renal failure on dialysis, this is the worst patient you can get. Whatever you do is not going to work. Even bypass, stenting, whatever you're going to do. Even we did studies one time and about heel ulcer in patient with on dialysis. And we found these patients, they will never heal. Even if you do bypass, stenting, and even we recommend at that time from that paper to go with the primary amputation. If patient diabetic, renal failure on dialysis with a heel ulcer, most of the time it ends with the amputation. I mean, you're going to try your best to save him, but prepare the patient from the beginning that he may end with amputation. Right, Omar?
Right. I remember the paper comparing a patient with 3-risk renal failure or heart disease, ischemic heart disease, or liver cell failure. The worst group is renal failure. And there is a good argument that if you are already diabetic with a small vessel disease on dialysis with renal impairment, you probably will end up by amputation. And this is, in my experience, quite justified due to the worst prognosis due to renal impairment. We don't know why is the reason, but it's a fact on the ground. Whenever there is comparing two groups, always the patient with hemodialysis come at worse. So it seems their blood vessel don't respond well to what we are doing. I totally agree with you.
Yeah, thank you. All right, let's go, Ahmed. Now the question.
Okay, first answer. Patients on hemodialysis benefit from carotid endarterectomy similarly to patients not on hemodialysis. That is incorrect.
Yeah.
B. Patients on hemodialysis who have asymptomatic carotid artery stenosis have a lower risk of stroke compared to those not on dialysis. Those on dialysis have higher risk of stroke in comparison than those without dialysis. This is incorrect. The opposite is correct. C. Patients on hemodialysis have higher rates of perioperative stroke and death after carotid arterectomy compared to patients not on hemodialysis. Combined risk of stroke and death is higher among dialysis patients. I think that's the correct answer, C.
Mm-hmm.
Patients on hemodialysis require routine shunting during carotid endarterectomy. We don't have data for this.
Correct. So
E,
it doesn't make it different. Yeah.
patients on hemodialysis have higher rates of restenosis after carotid endarterectomy compared to patients not on hemodialysis. I don't know.
No, we don't have any data saying that. Many is not really stenosis and all things. It's just patient is sicker, you know, it's just sick patient. I mean, dialysis patients are the worst patient. I think the life expectancy, like a cancer, even sometimes worse than a cancer. They don't live long. So always remember, guys, hemodialysis patients are very fragile. They looks outside, looks fine, but they're very, very fragile. So the reason why we like to do all our AV access and the nerve block. Never do AV access and the general anesthesia. You end with a major, major issue. So all dialysis patients, guys, very, very fragile. So just be careful when you deal with this kind of patients. All right, well, let's go to the next question. So we can go a bit fast. Here, 23. Who's going to take this one?
Can I take it, Dr.
Yeah.
Samer?
Yeah, please.
Yeah. This is a 60-year-old right-handed man with hypertension, hyperlipidemia, and a 40 back year history of smoking, present with left hemispheric transient ischemic attack. Workup with CT demonstrate a 60% left internal carotid artery stenosis. There is also an incidentally discovered 80% right internal carotid artery stenosis. Data from North American symptomatic carotid endarterectomy trial NASCET suggests that this patient is best treated by.
Okay, so they are talking about now symptomatic NASCET. Also, this is a very important trial. You need to read about it. NASCET trial, because still again valid until now. This they compare symptomatic 60% and above with medical management. And what did they find from these trials? That patient with symptomatic 60% above, they get better, less risk of stroke than medical management. So let's go through each. So this one has 60% stenosis in the left, which is symptomatic. It has 80% on the right, which is asymptomatic.
Yes.
Right?
Yes.
So what do you think you're going to do with this patient? Forget about the trials.
You will treat the symptomatic, Dr. Samer.
So you need to do the left current in that track.
Yes. Yes.
What about the asymptomatic, the right side? It's an 80%, right?
Yes. Yes. It is.
And this is. Go ahead.
Yeah. It depend the doctor on the center, as far as I know.
ما في center. Look. Center we talk when we are in like discussion between us. In the exam, you have to go with the trials, okay?
Okay.
Even if you're not convinced, I may not do it, but the trial, you have to see what the trial said, because this was the exam, you know?
Yes.
So on the exam, 80% asymptomatic ICA. Do you do surgery or not?
Yeah, it is indicated, doctor.
Okay, it's indicated. Again, in real life, you may not do that. Say, okay, I'm not convinced.
Yes.
It's okay. It's not somebody running after you. I mean,
Yes.
a trial doesn't force you to do something. Even guideline, remember, guys, I always somebody ask me, tell me, okay, the guideline said that if I do something different. I say this is a guideline. It's not like you have to follow. You can't get out of guideline as far you have a reason why, you know.
Okay.
But it's nothing in the book or trial or guideline tell you have to do it. This is just kind of recommendation. But everyone has his own experience, because maybe because criteria doesn't depend on every patient. Every patient is different upon his medical condition, financial condition, social condition, a lot of things, what you have. So everything you have to make a judgment. So in your real life, you take a recommendation from a guideline as a guideline, you know. But in the exam, you just answer as a guideline, okay, or what the book said. Don't go with what you think is right or not, okay. So in this one, according to the guidelines, you have to do the left, and later on you do the right, correct?
Yes.
Okay, let's go to the question and see what they say.
So A is best medical therapy, including high intensity statin and dual antiplatelet. We said it's incorrect. He need the endarterectomy. Best medical therapy combined with left carotid endarterectomy. This is correct for the left.
Okay.
And C, best medical therapy combined with left carotid endarterectomy followed with at least 6 weeks later by right carotid endarterectomy. This is right.
Okay.
Best medical therapy and carotid endarterectomy only if the patient experience a hemispheric stroke. This is wrong.
Right.
Best medical therapy and carotid endarterectomy only if the left carotid stenosis progressed to more than 70%. This is incorrect.
Why? Because the trial is 60% above, correct?
Yes.
So you don't
yes.
have to wait.
Yes.
So you have two best answers. You have B and C, correct? Looks you said correct.
Yes, I will go with C.
So which one do you think is correct? Because both looks correct. So what do you think is the right correct?
I think C, doctor.
No, it's B.
Okay.
You know why? Even though I said C, but it's B. You know why B?
No, honestly, no.
Okay, it's simple. See what the question, see a tricky question. Is the reason why sometimes I don't like tricky question. Look at this, it says data from North American symptomatic NACET suggest. So they're talking about these trials, okay?
Okay.
NACET trial is only for symptomatic. They have nothing to do with asymptomatic.
Correct.
See? So if you put C, this is not correct because NACET trial did not talk about asymptomatic. So you cannot use C as an answer. It has to go with a B.
Okay.
You get my point?
Yes,
if they didn't ask you about NASA, they said, what's the best treatment? I will go with C.
Okay.
But because they said, what's the data from North America, from NACET, then they want to talk about this trial. Unfortunately, the asymptomatic, they don't talk about any asymptomatic. They have nothing to do with asymptomatic because they have different trials.
Okay.
So nothing, this trial count about asymptomatic. So you cannot put an answer here. So on this one is B because they mentioned the trials. Okay?
Yes, correct.
Dr. Ahmed is
Ahmed
raising
has a
his
question.
hand.
Yeah.
Yeah.
Go ahead, Ahmed.
There is also another problem with C. They said 6 weeks later, whereas the most benefit is accepted within 2 weeks. The number of to treat is totally different. To 1 to 125 to achieve anything beyond 2 weeks. That's another problem. But NACET, in general, they divided them into two groups. First group from 50 to 69, the benefit was not as good as those from 70 to 99%. But both of them, they receive benefit in both groups. Even this one, 60% would benefit normally.
Correct. But you said about 6 week, Ahmed, this is for symptomatic. Asymptomatic, it doesn't matter after you do it after 6 weeks, 10 weeks. This is about benefit for 2 weeks or 6 weeks. This is for symptomatic. But
then this is the NACET.
We don't have. Sorry?
NACET is for symptomatic.
Correct. But you told me, see, it's wrong because they said 6 weeks for asymptomatic. Because 6 weeks, they said for right carotid endarterectomy. You see my point? When you talk about asymptomatic, then it doesn't matter if you do 6 weeks after a year. We have no time. Symptomatic, yes, it has to be done within 2 to 4 weeks or to 6 weeks, you know. But asymptomatic doesn't matter. So C, I think if they tell me what the best answer, I'll go with C. Because I think if you go with the data, then you have to do the symptomatic first. And after, some people 2 6 weeks, it doesn't matter really. Whenever I feel the patient's fine, then you do asymptomatics. But if you go with the NACET, as you said, it's nothing to do with asymptomatic. So you have to go with the answer D. All right?
Dr. Samer, C, according to the US guideline now.
Ahmad, you are with us? Sorry, I didn't see you.
I'm going to step in. I have to go back to the OR, but this is really
sorry, please,
So, so let me just summarize what we do here in the US at least. So, so in this patient, if you have a TIA, then you know, this has to be done carotid endarterectomy or carotid revascularization for any lesion above the 50% within 2 weeks. If it's major stroke, they wait 6 weeks. More data now showing that to do it, you do it on the second week, not the first week, is better than doing it on the first week. In terms of women, if you have a stenosis, symptomatic stenosis that just close to 50%, most people now, they do medical therapy for that. In men, they found to have more strokes. So, so waiting 6 weeks for a TIA, I think that's not correct, you know, in general. Usually 2 weeks, you know, for TIA. And, you know, but if someone has, you know, head bleed or something, then he can do that in 6 weeks or at least 6 weeks you wait. So that's really what we do, the guideline right now in the US and what the current practice.
Okay, Mohammed, let me ask you, this patient, if you come to this patient, what do you do? This patient
had a TIA.
Right, and he has asymptomatic on the other side. Yeah.
I would treat the symptomatic side like within 2 weeks, and that's what I would do with this patient. And then
what about the other side?
4 to 6 weeks after that, 80%, that would require also treatment. You know, I don't treat 70% in my practice. I treat them with medical therapy, but anything above 80%, even though the guidelines say, you know, 70% and above, you can treat with those patients.
That's correct. That's exactly what I said. Yeah. So 60% stenosis, 800 8 and above, we do it later on. Yeah.
Yeah.
Ahmed, you have a question? Go ahead, Ahmed. You can stay with us, Muhammad.
Yeah,
stay
the
with
comment
us.
to
We almost finished.
I have to go back to the OR, so hopefully.
Okay, good. Thank you for sharing us.
Sorry.
Thank you, Muhammad. That's okay.
So the suggestion of Dr. Jaber, that they would operate the second one, the asymptomatic side within that period, assuming within 3 months, for example.
Usually we wait minimum 4 to 6 weeks. You wait between the two, usually, because of the edema, the swollen, and everything. Now, with we do TCAR for these patients. We don't even wait that long, you know, with the TCAR if you don't stent or TCARs. But normally, if you do surgery, you wait about 4 to 6 weeks between the two carotids treatment. So,
how about the data that suggests that hyperperfusion is higher within 3 months period of doing the first one, the symptomatic one?
It doesn't matter hyperperfusion. You know, you're talking about. You know, already within weeks, the brain adapts to the revascularized side, and then we're talking about 60%. That's really, there's not much low perfusion. You're not treating perfusion here. You're treating a distal embolization. You know, when you do a carotid, symptomatic carotid, you're not really treating a perfusion problem. It's not like a claudication and you're treating a carotid artery. You do that sometimes if it's high-grade stenosis, but the main treatment for carotid disease is really distal. It's a ruptured plaque. You know, you can have a stroke from, you know, ruptured plaque, and that's why you treat it. Occasionally, if people have cognitive dysfunctions, have some dementia, they're saying you treat these with very high, you treat these for that. But the overwhelming majority you treat for preventing stroke, basically from ruptured plaque. That's really why you treat them. So,
thank you, Muhammad. Very appreciate it. Thank you, Ahmed. I think what you mentioned that within less than 3 months, because the criteria we said high risk criteria for hyperperfusion syndrome. Correct? This is what you mentioned.
Yes, correct.
Yes, but Muhammad, Ahmed, please remember, as I said, this is somebody wrote this paper. It's not mean we have to follow it. Please, guys, I mean, it's not like Metal Quran. If somebody came with this criteria, it doesn't mean he's 100% correct. Doesn't mean I have to follow him. Everyone has his own experience, you know, and every patient is different, depending how his medical condition, how is his situations, you know. So yes, I mean, in the book, you can answer this one, but in real life, you don't have to follow. No, I do it in 3-4 weeks after surgery. It doesn't matter, you know. And not everyone writes something or put a criteria that means 100% correct, you know. So it is correct for exam, but in real life, like Muhammad, he mentioned that, you know, he does it after 3-4 weeks or 6 weeks, it depends. But I don't think this makes a significant for reperfusion syndrome. Anyway, well, let's go one more question. We're done, guys. The last question. We won't take the last question because we're running late. 24. Abdullah, you start. Let's go finish with you, Abdullah.
Yeah. A healthy 46-year-old man struck in the right neck with a piece ball with significant impact to cause surrounding pain and bruising. 2 days later, he presents with a worsening right-sided headache and fluctuation, left arm weakness. On the exam, the left arm is paralytic, and there is a right-sided carotid ptosis and meiosis. CT angio demonstrate a dense cap narrowing in the internal carotid artery, causing a high-grade stenosis. Regarding open surgical reconstruction for this patient. So this is case
before
of
dissection. We go, correct, dissection, right?
Yes.
So what the best treatment for carotid dissection? If symptomatic or asymptomatic?
Asymptomatic, conservative. Symptomatic, if there is no flow limiting, conservative. And if there is symptoms, I think we should go with the stent before surgery.
Right. I mean, if it's just a dissection, even symptomatic outreach, but if he has like high-grade stenosis, you know, then I think you have to consider what you get is to go surgery or stenting.
For this case?
In general, if you have dissection.
Stenting.
Why not surgery? Because surgery is very complicated. The dissection go all the way to the base of the skull. So really, it's very, very difficult, you know, to tag it and all the things. So really, I mean, dissection is one of the cases where they do very well with the stenting, either cover or uncover stent. But they do very well. So I don't know why they come with a surgical reconstruction. I mean, really, we have to do treat dissection with the surgical. But anyway, if you decide to go with surgical, I think weaker question. But I don't think you can benefit from this question that if you have a dissection, please treat it conservatively. Unless it's failed or patient symptomatic or high-grade stenosis, then you may consider stenting.
Doctor, last time we had a case of dissection here in the review, and was the symptoms only headache, and we consider it as asymptomatic since he doesn't have TIA or stroke. So these symptoms, headache, fluctuation, and left arm
weakness. Left arm weakness, Hona. Headache alone is not, but left arm weakness is the TIAs.
Okay.
Correct? Fluctuating left arm weakness. So this is a high-grade stenosis. I think this is the symptoms here. I think we need to treat him. So I will go with the stenting here. So if you decide to go with surgery, what do you do? Let's go one by one.
A, exposure of the internal carotid artery to the level of the skull base is frequently beneficial. Let's see the others then. Thromboendarterectomy and batch repair are preferred over surgical bypass. Maybe.
We don't know. Nobody said that thromboendarterectomy is better. It's not endarterectomy here anyway, unless you want to take the flap. Okay.
Thromboendarterectomy and batch repair for dissection are associated with fewer complications than atherosclerotic carotid artery stenosis. No.
No, because they say go all the way to the base of the skull, where the endarterectomy is very localized. Correct.
Surgical ligation of internal carotid artery is the preferred method of management. No.
But can you do it? Can you ligate it?
We should do balloon occlusion test on the contralateral.
Yeah. So I think I will do it. If you decide to go surgery, I will do occlusion because sometimes you go and say find the paper artery like a paper, you have to ligate it. So if you do an occlusion test and it's negative, it just gives you more relief that you can go and ligate it. But it's not the preferred, but it could be one of the management. Yes.
Limited direct repair of the vessel with intimal resection is sufficient in a majority of cases. I think I will go with A.
Yeah, but you see, it's a great question. I don't like this question because they didn't learn anything from this question. If they should, I think they should talk about stenting is better. But anyway, dissection, guys, please treat it medically. But if symptomatic, then I think stenting should be your best option. Omar, you want to add something about dissection?
No, nothing really. I think there is Dr. Ahmed raised his hand.
Okay, Ahmed, go ahead, please, Ahmed.
Dr. Samer, is the target when stented, if we stented, to cover the entry tear all the way? Just like type B dissection, we cover the entry tear and that's our target.
Not really. I mean, it depends how the stent try to most, but you don't have, you know. I think most of the dissection end, I don't know, for some reason, at the base of the skull. I see dissection going. If it go all the way inside, I would treat it maybe conservatively. Again, I mean, even with dissection, we try, even symptomatic, we try conservative management. But if you get to, he's getting fluctuating left arm weakness, he's fluctuating, he's getting like crescendo TIAs, then we have to treat him with the stenting.
Yeah.
But even dissection with symptom, I'll treat it with medical first before I jump to the stenting.
I'll just add, I'll just add that this is not like the dissection that we see in the aorta because there is a diseased wall. Here, this is someone age 46 with normal wall carotid, and this is post-traumatic. Usually in post-traumatic, if you cover the inflow to the dissection is sufficient because the wall is not diseased. It's not like someone age 70 and his aorta is friable. The problem with surgery if you're unable to get a distal control, so if the dissection is very near to where you put your clamp of the internal carotid to control the artery to do the procedure, then definitely it is much safer to do the carotid stenting. And usually they are not as difficult as diseased vessel, not like dissection with autoimmune disease, or dissection in the diseased vessel, or dissection with atherosclerotic plaque. This is normal patient. He's fit just to play basketball, and this have caused a tear into the artery. And one of the important point is worsening right side, because this means that you have a stroke evolving, what they call it crescendo TIA. And this is an acute neurological emergency. So you must call right away, make immediate MDT meeting once patient present within 1 hour. You make a phone call MDT. Usually what wins is the neurointerventionist. He will tell you, I will cover it with an immediate stent and will put him under full monitor. Usually we get the overhand if the dissection is in the beginning, or let us say first 1 or 2 centimeters of internal carotid. But the common is that I see in the post-traumatic is near the base of the skull. That is why it is, let us say, the neurointerventionists take the overhand. But I just want to say that this is not the disease that we see dissection with a diseased vessel. This is a normal vessel with an acute post-traumatic dissection that is gradually closing up. So, I will go with what you said, Samer.
Thank you very much. I think we get to the end of the session today. Any question before we leave?
Yes, Dr. Samer, just one question, please. You mentioned about the elongated ICA and tortuous that should be significant kinking to those operate on them. So when to say this is a significant kink?
We don't have any criteria. As I said, we need an MDT meeting. So you cannot depend only on the radiology result, or and Omar, he mentioned you don't have really a good criteria.
No, we don't. Yeah, that's right.
You're right.
For duplex scanner, anything above 180-degree kink is severe kink. So let us say this is an internal carotid artery. If you get this is what's called angulation. If you get it up to this level, this is called 180-degree kink. And usually it corrects by 180 degree and goes up. Sometimes it make a full circle, which is, so the carotid artery become like this, complete circle and goes up. And this is 360-degree kink. What is significant is anything above 80. So if this is the artery would go down, this is 180-degree, then it is severe kink. This is definition by duplex scanner. We don't have definition of severe kink by angio, and we don't have definition by vascular surgeon. But we have just anatomical description of the kink, usually by how many degrees. I hope I'm clear.
Yeah, it's very clear, Omar. Thank you. But the point, guys, when you have a kink, you should treat it medically. Even symptomatic has to be treated medically.
Yeah.
And let's to the end point, as I said, because we don't have a criteria to tell us when you interfere. Mainly is the symptoms. So patient with asymptomatic, leave him alone. With symptomatic, we start on aspirin and statin. Then even though he's still getting TIAs, then I have to sit with the neurointervention and say, guys, do you think it's from here? Maybe something else. Maybe he has small bowel disease. Maybe he has something else. If everyone convinced this is the symptom from where, then we do a surgery. So I don't think this degree of stenosis tell you when to operate. Is more the symptoms.
Yeah.
Because you cannot say like severe stenosis, like, kink 90% and patient is something you can take him to surgery, or even like mild symptom which is controlled with aspirin and statin, take him to surgery. So I think mainly try to concentrate on symptoms than on degree of stenosis. The reason why we don't have 50-60, it's just said severe stenosis plus symptoms. Okay. All right. Any other questions? Thank you, Omar, for staying with us. Really appreciate you. Really always,
That's okay.
Benefit from your great experience. So thank you
It's
for
a pleasure.
sharing your
It's always
with
a
us.
pleasure.
Thank you. I really appreciate
You're doing remarkable
Thank you,
job.
everyone. I will see you next week. You take care.
Okay.
Bye-bye.
Bye-bye.
Thank you.
Take care.